my deepest honor and pleasure to present Professor the godfather of IVF in Egypt and Middle East. Dr. Maghraby is head of the Egyptian Foundation for Reproductive Medicine and Embryology, EFRI. He's professor of obstetrics and gynecology, Alexandria University, training in Pennsylvania, Philadelphia in 1990. He is head of board, general director of Shadby Hospital from 2009 to 2011, coordinator Egyptian Fertility Society, Reproductive Endocrinology and Molecular Biology Interest Group, director Alexandria XCIVF Center, Private Center. لازم بنقول بالعربي إن هو بيمثل مدرسة العطاء في مصر. Original School of Give in Egypt and the Middle East, whether for science, practice, advice. My deepest pleasure to present you, my dear professor and teacher. He is going to address protocols for endometrial preparation for frozen embryo transfer. Why should we settle for less?
Should I present or should I tear into cry? Very much. This is too much for me. No. Don't believe her. She is a dear friend of mine. She's a dear friend of mine. And I'm very happy and honored to present. And I would like to thank Professor Zarqawi, Professor Zakaria, Professor Nuruddin, and the Association for Scientific Research of the IRIFV. Thank you very much. Thank you very much. Thank you all for considering me for such a prestigious meeting. My time is 30 minutes. 30 minutes. Share screen. And I like to thank the previous speaker for facilitating my job, actually. So my talk is about natural versus HRT cycles in frozen embryo transfer. Why should we settle for less? Iman, you can hear me, right?
Yes, I hear you, Professor.
This is good. Thank you.
I tried to say this in French, I couldn't. But this is the title in French. Okay. So the incidence of freezing is increasing because vitrification is improving, because we're using more freeze-all cycles, and because of PGT. Embryos can be frozen at cleavage stage, day 3. They can be frozen at day 4, compact morility, or they can be frozen at the stage of expanded blastocyst. To prepare the endometrium, there are several methods. The most famous currently is the HRT, consecutive estrogen and progesterone, true natural cycle, and modified natural cycle. And the time of transfer, as the previous speaker stated, depends on the protocol that is used. And currently, low quality evidence indicates that possibly a natural cycle could be better than HRT. So the theme of my presentation is that why should we settle for this? Why should we keep doing HRT when we can do more natural cycle with better outcome? So the different methods for preparing the endometrium for frozen embryo transfer include hormone replacement treatment with or without GnRH agonist suppression. The more friendly way is to do it without GnRH agonist suppression, and actually there are no indication that suppression with GnRH agonist improves the results. Through a natural cycle, it depends on the in women who are regularly cycling, and this depends on the occurrence of the LH surge, and it can be used with progesterone supplementation or without progesterone supplementation of the luteal phase. Modified natural cycle, when you replace the LH surge, the spontaneous LH surge, with a bolus of HCG, 5,000 or 10,000. And in this case, you don't really need to supplement with progesterone. Mild ovarian stimulation is actually mainly done by letrozole with or without HMG, and then you conduct the cycle as you are doing in regular IVF. It is not enough to consider ongoing pregnancy rate, abortion rate, and cumulative live birth rate as an outcome. You have also to consider the obstetrical outcome. You have to consider neonatal outcome. You have to consider maternal problems that can happen with different ways of preparing the endometrium. Start first with hormone replacement treatment, HRT. The two methods are either to use a fixed dose of estradiol valerate from the beginning, from day 1, day 2, or day 3, 4, 6, or 8 milligram. The common practice is 6 milligram till the end, till the endometrium improves, and then you switch to progesterone with final details that I will mention later. Or a step-up method, you start with 4, then 6, then 8, or 2, 4, 6, and there is no indication that the fixed dose is different from the step-up dose. So the classic practice is fixed dose. Oral estrogen versus transdermal versus vaginal. Vaginal estrogen is not popular, except when endometrium is very thin and you try to improve the endometrium. So the two common ways are oral and transdermal, and there is a conversion rate to give the same dose, and the oral is the most popular. The duration of estrogen priming, should we do it till the endometrium reaches 7 triple pattern, and then we switch to progesterone, even if the estrogen duration is 7 days? Mostly, you have to continue till 10 days or more. So even if you have an endometrium that is good on day 7, you have to continue for 3 more or 4 more days to achieve a period of 10 days or more, and then you switch to progesterone. What is the maximum duration of estrogen that we can give? You can give it for a very long time, 30 days, 36 days if you need. So you can change the duration of estrogen also for scheduling. You want to skip the weekends, so you can change the duration. You can prolong estrogen for 3, 4, or 5 days, etc. Progesterone administration was explicitly mentioned in the previous presentation. Vaginal alone seems not to be sufficient. Intramuscular alone, or intramuscular and vaginal. The day of starting progesterone is for cleaving embryos LH +3 in natural cycle. The duration of progesterone administration before ET differs between cleaving embryos and blastocysts, as we will show later. And the duration of progesterone after pregnancy is interesting because in HRT, it seems that you have to continue till 10 weeks, and this is also controversial. And sometimes people continue for longer times. The classic teaching is to change progesterone once the placenta takes over. So the time of embryo transfer depends on the stage of the embryo. So if you are putting back cleavage stage embryo, you put them in HRT cycle on day 3 or 4 from the start of progesterone, mostly day 4. If you are putting back blastocysts, you put them day 5 or day 6 of progesterone, mostly day 6. Day 7 is associated with lower pregnancy rate. In true natural cycle, cleavage stage is transferred on day LH +3 or 4, and blastocysts are transferred on day LH +6, so 6th day after the LH surge. In modified natural cycle, the blastocysts are transferred on HCG +7, day, because with LH, ovulation occurs in 24 hours. Of course, it can be delayed. With the HCG, it occurs in 48 hours or something. So these are the different timing of embryo transfer that are associated with success in frozen embryo transfer. How true natural cycle is performed? Basal ultrasound, and then whether you use progesterone basally or not is controversial. If you use progesterone, you don't want progesterone to rise more than 1.5. Some people consider the cycle actually progesterone is high at the beginning of the cycle. Ultrasound monitoring is done day 6 or day 8 or day 9, the beginning of the ultrasound monitoring, and then you will monitor for LH either in the serum or in the urine. Of course, it's easier in the urine, but this occurs 24 hours later than the serum. The definition of the LH surge is important because sometimes it is 10, more than 10. Some centers use more than 10 LH milli international per ml. Some centers use 17. Some centers use 20. To make sure that it is the LH surge, you need to document progesterone rise after the LH surge, or a drop 30% of estrogen after the LH surge. So this is the natural cycle. Sometimes progesterone rise before the LH surge. If it is only 1 day before the LH surge, it does not make a difference. If it is 2 days, you have to cancel the cycle. Modified natural cycle, exactly the same. The difference is that when the follicle rises, when the follicle reaches 17 or 18 millimeter, some centers 20, you trigger with HCG. You give 5,000 or 10,000. You give the minimal dose that guarantees ovulation, because higher doses will affect the endometrium and close the window of implantation earlier. So this is the dose of HCG in modified natural cycle. Now, if LH rises before you trigger, the results could be bad. So the trick is, if LH rises before you give the HCG, you shift it to true natural cycle. You don't give the HCG, because a lot of data shows that the results are less if LH rose before the HCG trigger. So based on available evidence, FET should be timed on LH plus 6 in true natural cycle, on HCG plus 7 in modified natural cycle. Again, they are the same exactly, except for the fact that you give HCG instead of waiting for the trigger in modified natural cycle, and this is easier or more convenient. So is luteal phase support needed in true natural cycle or modified natural cycle? You may give with in true natural cycle progesterone with measurements or without measurements, but it doesn't make sense to give progesterone in modified natural cycle when you give HCG, because HCG guarantees that progesterone is adequate for at least 7 days after the injection. And extra progesterone will change the capability of the endometrium to receive the blastocyst or the cleavage embryo. So in a recent network meta-analysis, no difference in live birth rate was reported between true natural cycle and modified natural cycle. So we call it all natural cycle, either true natural cycle or modified natural cycle, and you are free to use according to your convenience and according to your expertise. If we include HRT now in the comparison, and this is the theme of network meta-analysis, no difference in live birth was noted between true natural cycle and modified natural cycle and HRT. Surprisingly, cycle cancellation was significantly less with modified natural cycle as compared to HRT. Why? Because there is more thin endometrium with HRT. All the people who have been working in FET for a long time know now that with HRT, you may have a slightly higher incidence of thin endometrium as compared to the natural cycle of those women that you are doing FET for. Possibly they don't receive estradiol variate properly. Possibly the natural estrogen is better for them. So possibly there is something in the in the follicle other than estrogen that helps the endometrium. So, but this is what is happening. My thoughts are building up in the line to please move away from HRT, including myself, because I'm using HRT. So this is what I am saying. In HRT cycle, the early pregnancy loss rate has been alarmingly high in some reports. So HRT, more cancellation because of the endometrium, and more pregnancy loss. And myself, I witnessed this. I witnessed a reasonable, I mean, a decent pregnancy loss rate with HRT despite using high progesterone levels. HRT was associated with significantly lower live birth rate when compared with natural cycle. So now if we are aiming at success, our method is not so successful because natural cycle could be more successful. And this is the last a report recently in Journal of Assisted Reproduction and Genetics in 2021. So what is the problem with HRT apart from what we've said about the reproduction? More hypertensive disorders, more cesarean section, more postpartum hemorrhage, higher microsomia, higher incidence of abortion, and risk of preterm and very preterm delivery are associated with HRT. So why? Why should we settle for less? Why should we settle for a reproductive outcome that we thought is better than natural cycle, then it turned up that it is the same or lower than natural cycle? Why should we settle for a lower obstetrical and maternal outcome as compared to natural cycle? So I started asking some of our friends, either through the internet or by phone calls. So this was from Professor Khalaf when I asked him, do you do HRT or natural cycle? He said that we do natural cycle increasingly, and it is as effective as medicated cycle without the added cost and the effects of hypertensive disorders and the related outcomes. So this was Yaqub Khalaf. And then I asked Bob Casper from Robert Casper from Canada. They said, now we're completely natural cycle or minimal stimulation cycle through the result. So this was Bob Casper. I called Panagiotis from Greece, and he said, in response to, do you do natural cycle? He said, yes. We monitored natural cycle either by serum LH or urinary LH. And the indication, I asked him, what are the indication for using natural cycle? He said, all patients undergo natural cycle, except patients with oligomenorrhea or patients who live far from Milan and they cannot be followed up. I asked our friend Pierre van der Zwalmen from Brussels, do you do natural cycle? He said, no, we don't do natural cycle. So this is another opinion. He said, we perform rarely the natural cycle, and Pierre works in several centers. He said, in all centers, they do HRT, but possibly some centers use natural cycle. We have a very important meeting of our department, and yesterday, Panagiotis Drakopoulos from UZ Brussels and from Greece was presenting, and I asked him, he said, mainly we do HRT, and in UZ Brussels, they are starting, UZ is a very prestigious center, and he said that they are starting to shift from HRT. And I asked him, why Draco, why do you do HRT cycle despite knowing that there is currently low quality evidence indicating that the obstetrical outcome and the pregnancy rate is lower with HRT? He said, convenience and the lack of possibility to monitor patient and the expenses. Attending was Professor Hisham Anani in the floor, and I asked Hisham, he said, since the evidence came that the obstetrical outcome is lower, we stopped completely doing HRT. So I said, what are you doing now? He said, we're doing minimal stimulation with letrozole. I asked most of my friends, the national experts, including the icon that is sitting with you, Iman, and they said they are doing HRT, including myself, of course. So we all do HRT. I looked into, I asked them 7 days ago to bring me the last 50 cases of FET in our center. And you see that the pregnancy rate actually is high. The pregnancy rate is the last column. And this is HRT. It is almost 70%. So these are the 50 patients. And it is very difficult when you have 60 to 70% pregnancy rate to play with it. We transfer either compact, we freeze at compact moruli and transfer as blastocyst, or we freeze as blastocyst and transfer as blastocyst on the same day. I'm doing this as a randomized control multi-center trial with Professor Emmanuel Gendi and a lot of centers in F. The preliminary data seems to show that possibly freezing at day 4 and transferring at day 5 is better than freezing at day 5 and transferring at day 5. Knowing also that it's not a problem of survival because the survival rate is more than 90% in both techniques. But we'll see when the results of the multi-center trial comes out whether freezing at day 4 or freezing at day 5 is better. So in conclusion, Mr. Chairman, Mrs. Chairman, and dear friends, FET is increasing, is improving. The method of preparing endometrium is controversial. A paradigm shift away from HRT back to nature is currently witnessed because of the evidence, although it is a low quality evidence. And why are we hesitant to follow the recent low quality evidence? Convenience, success. We have a very successful method HRT, and we don't follow up our babies. They go and deliver somewhere, so we don't see them. We don't see the problem with women. We don't see the problem with. So, but we hope that as a community with your respectable society and with EFRI, that we can do some work about this to possibly either stay where we are or we shift based on evidence. Thank you very much.
Thank you, Professor Hassan, for excellent and challenging presentation as usual.